today my role is to put into context what is the role of contemporary lipid management in older adults. And so as we think about older adults, we are definitely getting closer and closer to that each year, Carol, but we're not old and we're not elderly, and we're all very active. So let me ask the audience really to provide a show of hands. How many people take care of lipid patients in their practice? How many people take care of or write cholesterol prescriptions for patients older than 70? Very good. How about 85? Excellent. As many of you probably take into consideration every time there's a patient across from you in the exam room, much of the consideration comes into balance of what is the clinical benefit, what is the risk. What I'm going to do today is share with you 3 guidelines that have all been written or presented in the last year. And for many of us, the formula was simple when we were in training, and it does remain pretty simple at this point in time, but how we approach it seems to be shrouded in a great degree of controversy with the advent of the American Heart Association and American College of Cardiology cholesterol guidelines that were presented and published back in November of last year. I'll go over that guideline, but I'm going to predominantly focus on what does it mean for the older patient. And I'd like to share with you some data in terms of what that actually means, in terms of how you put it into clinical practice. So there's 2 guidelines. One was in October 2013 last year, the elderly guideline that I'll share with you, then the AHA-ACC guideline that took a different look at it, and then most recently, 2 weeks ago, the National Lipid Association presented their lipid guidelines. So let me ask the question, how many people actually pay attention, or I won't say it that way, how many people are aware of the ACC-AHA lipid guideline from November 2013? Okay. Of those people who are aware of it, can you tell me, would you raise your hand if it provided greater clarity in how you treat your lipid patients or less clarity? So let's go with greater clarity first. Okay. And then how many feel that it provided less clarity? Okay. Very good. By the end of our presentation today, I'm hoping that we'll be able to provide some common guidance where there are elements and commonalities for all 3 guidelines that will probably bring us back to the past in terms of how you're going to might be able to consider treating lipid patients at the bedside in 2014. As Carol said, I am a full-time employee of Merck & Company. I am involved in lipid research. My sole role right now is to develop new medicines for preventing cardiovascular events. And I lead a strategy team that helps be able to help develop them and then be able to talk about them. I am a member of the MOA, the AOA, the American Heart Association, the National Lipid Association, and the American Diabetes Association, and I happen to have the privilege of chairing a steering committee or an advisory board for some of the best cholesterol thought leaders in the country and also in the world. So I'm bringing to you a common experience that I've had in talking and researching with many of these folks, but also I'm bringing to you the experience that I share with each one of you here in the room. So I'm hoping that you'll be able to balance the conversation here. And I'm not going to present any information that is my own personal point of view until we get to question and answer. I'd be happy to ask and answer any question that you may have. All the information I'm going to share with you comes from these 3 guidelines, and then perhaps sharing with you some insights on where we might go from there. My objectives are to update the recent guidelines as we've discuss those controversies and commonalities that have arisen just within the last 12 months, or actually the last 6 months, and then to discuss how a prudent bedside approach in treating cholesterol in older patients may be able to occur. So how can we cut the wheat from the chaff? And that's the objective, the final objective of trying to get through some of the information. So like I said, it was October 28th in 2013, where the voyage from the adult treatment panel 1, 2, and 3, and the ATP4 update from 2004, which was the last nationally representative guideline in the country. Prior to that, the NHLBI had commissioned ATP4 and has worked for the last 6 or 7 years to come out with a final guideline. And then, due to a number of reasons within the Beltway, the NHLBI decided to hand guideline writing off to major professional societies, and in this case, it was the American Heart Association and the American College of Cardiology. This particular guideline really reflects a continuation of the work from ATP3 and before. So let's put some very focused perspective on what it means for older patients, those who are 65 or older. Certainly we know that the grain of the US population and those of other industrialized countries has progressed unabated because more adults are surviving their senior years. So we're doing a great job, but now we're now facing the risk of balancing the burden of an increasing budget of taking care of patients who have survived their first or subsequent cardiovascular event. The number of patients aged greater than 75 was estimated at 18.6 million in 2010. That represents about a 6% increase of the, or 6% of the total population, and this group is expected to double by 2050. Population aged greater than 85 is growing the most rapidly. So it's not those 0 to 10, it's those greater than 85. The numbers are expected to reach about 19.5 million by 2040. And in 2008, 67% of the 800,000 plus cardiovascular deaths in the United States occurred in patients greater than 75. And in parallel to this increase, the older adult demographic, the number of Americans with CHD has increased to an estimated 16.3 million, more than half of who are greater than 65 years of age. And though we've improved and reduced by 25% since the year 2000, according to statistics by the American Heart Association, CHD is continuing to grow in either a stable or unstable manner. And the sequela, where we are now dealing with the increasing challenging of balancing quality and improving life, at the same time trying to manage costs. For stroke, there are about 7 million patients who've had a stroke, and the incidence has doubled with excessive age decades after 45 to 54 years. Peripheral arterial disease affects about 8 to 10 million patients. The majority of are patients who are greater than 65. Between next year and 2030, the annual cost related to ASCVD, if we bundle coronary artery disease, stroke, and peripheral arterial disease, this will almost triple from $84 billion to $202 billion. ASCVD undermines the functional capacity and independence and increases the reliance of long-term care, especially patients who have chronic kidney disease along with their ASCVD, and those who have chronic heart failure. The indirect expenses related to this are also expected to increase. Although people greater than 75 years of age account for only 6% of this population, 35 to 40% of the incident MIs and up to 60% of these deaths are attributable to MI occur in this age group. Now, some people may say that's the ultimate end game in terms of end of care life. Plus falls, plus infection, plus cancer. Now, given that CHD and PAD and atherosclerotic aortic disease and ischemic stroke as well all increase with this advancing age, The mandate for secondary risk reduction among older adults has expanded and has increased our attention here, because it's not only end of life care now that is the last week or last month of someone spending their final days in the intensive care unit or in hospice, it's caring for the long-term chronic ASCVD patient. So what are the major goals by the AHA and ACC? Number one is to continue doing the good work that we've been doing. That's to prevent or delay the progression of disease that results in these events. And by preventing these events, we can increase longevity, and we can increase productivity, and we can improve quality of life. And the yearly healthcare costs are likely to decrease if we have a more functional, working, or contributing adult population, no matter how they view that as they hit this time of their life. Secondary prevention of ASCVD also enhances the potential of seniors to perform activities of daily living and thereby maintain their independence. And that's where a majority of the healthcare costs is when patients lose their independence, then the downward spiral begins. Exact counterbalance to that is what happens when we have to weigh benefit and risk. And even though it seems that we would continue on, I think there isn't a day that goes on should we stop our lipid-lowering therapy in our patient after they've reached a certain time in their life, or if they've reached a certain loss of functionality in life. So goal 2 is to balance this out. What is the potential benefit? What is the potential risk? And we all have to deal even more with greater consideration the comorbidities, the polypharmacy, socioeconomic stresses, cognitive limitations that frequently confound these preventions. And at the same time, we have limited number of instruments that are able to help us predict benefit versus risk versus longevity. I'm not going to go through the detailed pathophysiology. You already know it. But summing it all up, it's endothelial dysfunction that leads to high blood pressure, inflammation, vascular stiffness, plaque formation, and disruption that are the major pathophysiological consequences of aging, and as well as certain lifestyles. These lead to the progressive rise in incidence of these events that we're talking about. We know that autopsy studies indicate that obstructive CHD is present in greater than 50% of women and 70–80% of older men. And we also know that older patients tend to have more extensive coronary atherosclerosis with a higher prevalence of MI, but also multi-vessel disease. It's not just in one stentable segment of the coronary arteries, it's more diffuse and extensive. We also see this in the coronary arteries, or the cerebrovascular arteries, carotids, and in the peripheral arteries, mostly of the lower limb. Although these patients are greater than 75, account for only 6% of the population, again, 30–40% of the events occur. CHD is by far the leading cause of cardiovascular death, and moreover, the atherosclerosis is a systemic process and hits all blood vessels. We do know that both clinical trials and observational studies show that increasing age is a powerful predictor. It's the most predictive variable in terms of trying to determine whether or not someone's going to have an event. And it's also the unmutable, the unchangeable risk factor that we're trying to extend. And therefore lies the confounding factor. What's really interesting is that survival rates drop dramatically in men going from 17 years and women from 13 years that are in the ages of 55 to 64 to just 3.2 years after the age of 75. And that hospital mortality is 6 times greater in patients older than 85 than someone who's less than 65. And the 30-day mortality rate is 7-fold higher. Those of us who work in the quality world know that that 30-day readmission rate is a key quality indicator for hospitals and systems, and we all have to work on that together. So stroke, we've begun to talk about it. It's 7 million patients. 610,000 who had their first, and 185,000 had their recurrent stroke that occur annually. And almost 90% is ischemic and not hemorrhagic in nature. The mean age of those dying from a stroke is about 80. It's about 60% women. The 1-month case fatality rate from ischemic stroke in Medicare beneficiaries is about 8%. And the residual disability rates are much higher. Ischemic stroke survivors greater than 65 from Framingham, 50% had residual hemiparesis, 30% could not walk, and 26% were institutionalized. So not dying of a heart attack, but suffering the consequences of a stroke can have long-term morbidity and mortality, as we all know. These costs are getting greater. Peripheral arterial disease holds the same. Rather than severe disability from inability to walk or talk, comes the progressive challenges that occur with increased number of procedures, as well as the increased number of amputations and disability in terms of surviving. The most important of those with a vasculopathy are those who are smoke or continue to smoke and have diabetes. By far, the most potent risk factors associated with peripheral arterial disease. The PAD in and of itself, if someone has symptomatic claudication, they're 3 to 5 times more likely to have a heart attack within the next 2 to 3 years. ASCVD risk factors that you've come to know are much higher in patients. Obesity epidemic is also extended into the older population. Recent examinations from NHANES suggest that 35% of non-institutionalized women and 40% of men in the ages of 65 to 74 years of age are obese. And that's with a body mass index of greater than 30. So those numbers compared to those greater than 65 are slightly less, and greater than 85 decrease because of decreasing body mass and muscle mass. And so the obesity epidemic begins to turn. Biggest identifier there is someone who's 85, who is now leaner than they were 15 to 20 years ago. Would they still benefit from therapy? From a multitude of therapies when we have to consider many different options in managing diabetics, especially diabetes is the ultimate consequence of obesity and subsequent cofactors. Nearly 2/3 of seniors are overweight or obese, so the epidemic continues and closely parallels that of the general population. However, there is a U-shaped curve in terms of morbidity and mortality that occurs, and that you see an increase of 1 million individuals that were shown to be overweight and were obese. Their mortality rate increased, but the ratio decreased over the course of time the older they got, again because of loss of lean body mass and adipose tissue at the same time. But a lot of the weight loss is exchanged from muscle mass loss, not adiposity. The effect of obesity on cardiovascular mortality is more questionable, one might think, but if they are suffering the consequences of cardiovascular disease as a result of their diabetes, that mortality is much more pointed and consistent with increased morbidity and mortality compared to those who do not. The effect of weight loss interventions in the older population has been modest and has not showed a long-term benefit. So weight loss programs may not be helpful, but certainly activity programs may be helpful. So here's the lipid controversy, is that lipid lowerings are important for secondary prevention. However, the cumulative effect of comorbidities, if you're a survivor of a heart attack, what are you going to be? What's going to get you next? So cancer, malnutrition, inflammation, injuries from falls, and accidents in older adults are associated with increased mortality rate. So it may seem that even though you're doing a good job in preventing that heart attack, it may seem that it's not making a difference. And that's the paradox in the fact that survivors lead to risk of dying of something else. This observation has been challenged for the rationale of lipid-lowering therapy in older adults. I'm going to try and share with you some of the evidence in terms of why we should not think in that manner, along with how do you weigh at the bedside in terms of whether or not you would continue lipid-lowering therapy as your patient gets older. Although total cholesterol and low-density lipoprotein cholesterol decline after that seventh decade, LDL remains strongly associated among their age-matched peers. So what is the evidence? We'll go over that briefly. We know that multiple randomized controlled trials prospectively looking at statin efficacy for prevention of heart attack or ASCVD events, stroke and PAD events, have included older patients. There are very few that have looked at older patients specifically, and they're all subsets of previously conducted trials, with the exception of a couple. These trials show that the relative risk reduction is similar in older and younger patients. So we look for heterogeneity amongst subpopulations. And statistically, we check to see if the results of these subpopulations are consistent with the overall population which the trial is powered to. So when we talk about heterogeneity analysis, we're looking to see if there's any specific differences. And the key point here is there are no differences in terms of preventing cardiovascular events with lipid-lowering therapy, specifically statins, as compared to younger cohort. Accordingly, the number needed to treat to prevent these events is much lower in older than in younger patients, mainly because the disease is more advanced. We know that within a 1 to 2 year period of time, lipid-lowering therapy can have a positive impact up to 5 years and beyond, and that because they have advanced disease as compared to someone who has a high cholesterol but does not have established disease, it takes much longer to find those patients, put them in trials. You're treating a relatively more well population, and it takes more patients to treat to show a potential benefit. So the numbers needed to treat, which is a number that managed care folks look at in terms of saying, well, what's my benefit, what's my risk? They look at that NNT quite frequently. So that's why that's an important piece there. I'm not going to go into a great deal of detail here. And most of you are familiar with the key lipid trials, but these are the trials that have a good degree of evidence in subsequent analyses that were pre-specified in looking at patients who are in the age group that we're talking about. So 4S with simvastatin, Lipid with pravastatin, CARE with pravastatin, heart protection study with simvastatin, PROSPER with pravastatin were the key pivotal trials. And it was really the heart protection study and the PROSPER trial that had the greatest number of patients that looked at patients with this age group. And they found two things. Number one is the lower you go with cholesterol, the better. And number two is it didn't matter how old you were to have a benefit compared to people who did not get therapy. It was HPS and PROSPER that led to the ATP3 update and focused on two populations where there was no specific guidance one way or the other, but ATP3 update in 2004 stated that there was sufficient evidence from both PROSPER and HPS to justify treatment of older persons, is the way they stated it in the guideline. So you see hazard ratios. You see the subgroups here in terms of the ages for these analyses. That didn't work out very well. Let's see if I... Let's do it this way. So the ages for these subgroups were 65 to 70, 65 to 75, 65 to 75, 70 to 80, and 70 to 82. And you look at the risk reductions that are relative and absolute. So 43 with a relative risk reduction, that's the number you usually see. And then when you change that to absolute risk reduction, 6. And then you saw improvement in all of these with reduction in CHD events. So it's the CHD event risk reduction where you can see this positive benefit. And you can see also the risk reductions or the primary endpoints in the comments section here. Well, that continued on beyond 2004. Improve-It came out and Treat to New Target with atorvastatin, SAGE, which was specifically looking at patients who were elderly. And that was the first trial that really included patients in a significant number up to 85. And then in meta-analysis of all trials, looked at patients from 65 to 82. And you can see that there were statistically significant event reductions in all these trials as well, adding to the body of evidence from when the first guideline recommendation came out for treating older patients. The meta-analysis that I'll show here include two. One was by Afalalo, and they looked at patients between 65 and 82 years of age. They looked at 9 secondary prevention trials with statins, and with a total of about 19,000 patients, 19,000 plus patients. In this age group, they saw statin-related relative risk reductions on all-cause mortality by 22%, CHD mortality by 30%, non-fatal MI by 26%. So they weren't dying of a heart attack, but it was all-cause mortality. And the need for revascularization by almost a third, and stroke by 25%. And the number needed to treat in this population was 28 to 1. And putting that in perspective in terms of other statin trials, the number needed to treat was essentially between 40 and 100 in terms of being acceptable from other trials. But specifically for older patients, this demonstrates a very good effect on treatment in patients with this age group. Probably the most important one, and I have the privilege of working with this group at Oxford, is the cholesterol treatment trialists group. They have patient-level data, and they've looked at all statin patients over 26 randomized controlled trials, about 170,000 patients, and it showed a relative risk reduction of major vascular events of 22% in patients from the age of 65 to 75, and a 16% reduction in those greater than that were older than 75, with an increasing or improved absolute risk reduction in that group. So it's this data from individual RCTs in the two meta-analysis that I've suggested to you that for this body of guideline writers back in October still suggested that an LDL goal of 100 with an optional goal of 70 for those who are at very, very highest of risk. And that included patients who smoked and especially included diabetics. So if there's ever a vascular path, that's the one that I see, that you have injury from your metabolic disease and you have injury that's self-induced from tobacco use. And the benefit was felt to be very positive. Statins also reduced the incidence of stroke. In a meta-analysis of randomized controlled trials by 25%. There's a secondary analysis of the stroke prevention by aggressive reduction in cholesterol levels, or the SPARKLE trial that showed a non-significant relative risk reduction in fatal or non-fatal stroke over 5 years when atorvastatin was used compared to placebo. But when they looked at it without CHD, in comparison, they saw a very statistically robust 26% relative risk reduction in stroke once they took out the mortality related to a myocardial event. So it was the myocardial or the heart attack event that was causing the death and morbidity. When you took that out, you could see a very clear-cut signal for stroke. And then for PAD, there are a number of studies, but this particular study showed there was not only an improvement in their events, but in patients who were trained in rehab to exercise regularly on a treadmill, aged between 60 and 85 years of age, before the onset of claudication. So they had either an ABI or a vascular Doppler, or they found peripheral arterial disease from some other form. They saw a 24 and 42% improvement in their walking time and in their pain scores after statins were initiated. Now, one that's quite interesting and controversial, because of the anti-inflammatory benefits of utilizing statins, everyone's thought that statins have other properties and other potential effects, including the inflammation surrounding a very chronic, stable bone disease, osteoporosis, and dementia. And there were several observational trials that suggested that statin therapy reduced the risk of progression to dementia. But unfortunately, especially with Heart Protection Study and PROSPER, two largest groups with older patients, did not see any improvement in dementia. There's been a number of case reports reported to the FDA that show that there may be an increase in cognitive capability. And outside of muscle pain, I would say a little bit of confusion or lethargy is probably one of the most frequently reported side effects of statins that is not really captured well in controlled clinical trials. So, however, is the anecdotal case reporting system to the FDA that was consistent across all statins, that all statins had a change in their package insert in about 2011, stating that there may be risk for decreased cognitive capacity. So that warning is now in all statin labels and continues to be so. So, summary, this is the overall evidence on why we should be considering treating older patients, and that this evidence supporting lipid-lowering medication for secondary prevention is credible all the way through 85 years of age. So we can have a discussion and debate whether or not someone less than or 86 or older should stay on their statin. There's plenty of evidence right now to suggest that there is risk reduction when utilizing lipid-lowering therapy, particularly statins. Secondary prevention guidelines advise lipid-lowering therapy regardless of the age in the majority of older patients, unless the patient is frail, has multiple comorbidities, and polypharmacy confound management. Well, which patient do you see that's in this age group that doesn't have at least one of those? All relies on your personal clinical judgment in terms of putting together what you see in front of you with the patient, their profile, your understanding of their functionality and their risk in terms of whether or not you will treat. So one of the key factors in all the guidelines is it's ultimately up to you. Our job is to present to you sufficient evidence whether or not that will help you in making that decision. Despite concerns of statin-related adverse events in older patients, these pooled analyses of many large clinical trials show no significant difference in adverse events in older versus younger patients, but then it gets back down to the details in terms of whether or not this specific patient has side effects or has the potential for multiple drug-drug interactions. Interestingly enough, and I still find this interesting because I still think fatigue and muscle pain are the major reasons why I consider stopping a medicine. Dyspepsia is frequently reported in those that are greater than age 80. And recent aggressive lipid-lowering trials, including TNT, SAGE, PROVE-IT, have all revealed higher incidence of abnormal liver function. So liver function testing is something to consider, even though liver function testing has been pulled from all the statin labels in the last couple of years. TNT did show that liver function tests increased similar to statin doses in older and younger patients. And so it may be the longevity that you're on a statin, perhaps a drug holiday may help. But that, again, is up to your judgment. We've talked about the ongoing problems with patients taking medications and being motivated to take medications. One of the biggest problems is adherence to lipid-lowering drugs in older patients. Statins are notoriously underprescribed and underdosed in this cohort despite their higher risk of recurrent events. Only 24% of patients greater than 65 and 15% of those greater than 80 years of age were receiving a statin at discharge after having their heart attack. And in one analysis, 23,000 Medicare beneficiaries showed this effect. Several factors we know impact this. The lack of knowledge regarding statin efficacy in the outcomes trials, the fear of adverse events, and I think for those starting statin, especially when they were branded and not generic, the number one reason for not starting was cost. The number one reason for discontinuing was fear of side effects. That the perceptions that the benefits diminish in the context of reduced life expectancy and mounting comorbidities is probably a major factor. Is, well, this patient's not going to live much longer. I'm going to start decreasing the types of medicines that they're being given. Muscular and neurological concerns are as important or more important as patients are losing their muscle mass. Certainly, these are the key risk factors in considering what dose and what statin that you might consider. Those who are female, small in stature, and have low BMI, those who are taking fibrates, those using other drugs that are impacted by the cytochrome P450 enzyme pathway, use of statins during surgery, decreased hepatic or renal function, fatty liver disease, where you lose functional liver cells, hypothyroidism, diabetes, heavy use of alcohol, especially heavy use of alcohol in the presence of extreme exercise. So what do we do? Although in clinical practice, it's easy to administer a statin, should be, for older patients with ASCVD, the decision whether or not to prescribe is based on weighing all the factors that you have available. So good history, physical, lab testing, and longitudinal experience with the patient. Life expectancy can be estimated by using appropriate multi-morbid tools rather than an actuarial data on saying this is how long this patient is going to live for their life insurance, but there are more precise tools. In patients with conditions that severely compromise life expectancy and quality of life. So those who have conditions where life or quality of life would be markedly diminished, and it may seem futile to continue such therapies, they may not be suitable candidates for lipid-lowering therapies. So start off with a lipid profile. In this particular guideline, to establish baseline is important, and I'll bring that up again when we talk about the new guideline that was published less than 1 month later, about 3 weeks later. And in very high-risk patients, a target of 70 or 100 is appropriate. If their LDL is high and they're lucky to have survived a high LDL, those with probably heterozygous familial hypercholesterolemia, 30 to 40% reduction is reasonable. And then those with ultra-high risk, especially the smoking diabetic, perhaps a goal of less than 70. Again, the further you push down on those targets or those goals, and this was specifically written in the guideline for older adults, is take that into careful consideration. But the data does show that if you go below 100 and down to 70, that there is an improvement in the reduction of events. In this particular guideline, and I'll bring this up here in a minute on where some of the controversy and confounding occurs, is that the non-HDL cholesterol, so you take the good cholesterol out, total cholesterol minus HDL cholesterol, that is the entire atherogenic lipoprotein. LDL constitutes about 70% of that, so it's a good marker, but this is a little bit more predictive. So look at the entire good, which I'll just simply say is VLDL plus IDL plus LDL plus small dense LDL. So the non-HDL is a very good surrogate to determine how much cholesterol is of the fraction that's delivering cholesterol toward the tissues. And then triglyceride goals less than 200. Statins remain the first line of therapy. They're relatively safe. but need to be age and dose adjusted. Those that are lipophilic, such as lovastatin, simvastatin, and atorvastatin, and those metabolized by P450 may have an increased likelihood of sticking around longer if they're under-metabolized due to competitive pressures from other medications. In terms of non-statins, non-statin lipid-altering therapy could be helpful as an adjuvant or alternate to therapy, and although specific evidence for most of their use has not materialized or not shown to be additional benefit on top of statins, and that's particularly true for niacin and fibrates. There's lack of evidence for bile acid sequestrants, and for cholesterol absorption inhibitors, there's no sufficient evidence that looks at statin versus ezetimibe plus statin, and that is in the Improve It trial, which should be reporting out later this year. That's one that I could state that I do have a personal stake in, and I'm involved in the conduct of that trial. So fibrates are effective, but you got to be careful. Older patients were not adequately represented in these studies, in that although fibrates in combination with a statin are particularly appealing for those with elevated trigs, the combination is usually associated with the increased risk, and this risk occurs more with gemfibrozil than it does with fenofibrate, which is considered to be a little bit more tolerable in patients. But extreme caution and lower uses with the statin doses when using fibrates when you want to consider lowering triglycerides or perhaps raising HDL cholesterol in your mix of therapeutic targets. Use caution. Nicotinic acid has lost some favor with the two recent trials, AIM High and HPS 2 Thrive trial, which failed to show a benefit of using niacin after getting LDL down to levels that were considered to be guideline levels and focusing on raising HDL. Niacin trials have not tested the benefit of using nicotinic acid plus a statin or nicotinic acid alone, at least in the last 40 years since statins have come out, in terms of what the total lipid effect is. So we know that niacin lowers LDL and VLDL and IDL, and it raises HDL. So the total lipid effect is really yet to be tested. And so have to be careful in terms of synthesizing what the data is telling us in these key clinical trials. And again, there is some evidence with cholesterol and niacin and cholesterol alone, but cholesterol has not been available in the market for a couple decades now, and cobicevilam does not have an outcomes trial. So there is no evidence at this point in time showing that bile acid sequestrants matter, especially the ones that are available at this juncture. And then, of course, the cholesterol absorption inhibitor, ezetimibe, this is what the guideline says. This is not what I say. It appears to be safe in older patients and effective at lowering LDL when added to statins. But again, the hard ASCVD outcome trial is yet to be presented. The trial is still ongoing, and hopefully we'll report out by the end of this year. Now, here's another controversy in terms of red rice yeast, flaxseed oil, the use of herbals and nutraceuticals. Trial evidence is paltry compared to what the evidence with statins and other lipid-lowering therapies is. So the risk of drug-drug interactions is high, and there is no credible evidence to show that this works. So this particular guideline in treating older patients says that there's insufficient evidence to make that recommendation. I'll just make a quick comment. Physical activity is still important in this age group. It's not medication, it's lifestyle first. So diet, exercise, smoking cessation. And some of the precautions for the elderly we've already talked about. And the biggest issue is that we need more data. And to Carol's point earlier, we should not treat the elderly as second-class citizens. They are productive members of society, and there's all the benefit to be able to look at that. So what I'd like to do just momentarily so that we can move on is just talk about the more recent guidelines. So just a couple weeks later, on November 12th last year, HAACC came out with a guideline that reported out on what to do about reducing blood cholesterol to reduce cardiovascular events. And it was specifically the use of statins. And the guidance is based on their marching orders from the NHLBI is look at level 1 evidence, which constitutes about 5% of all evidence, and rather than looking at the total body of evidence and then coming up with a consensus where they would be able to give us some direction in terms of how to make that decision at the bedside. They came up with 3 specific groups, those with established disease, secondary prevention. Don't have to have had an event, it just means you have to have established disease. So if it was diagnosed before having their heart attack, that's still considered secondary prevention. Those with diabetes, which has been a CHD risk equivalent, strong evidence, they recommend treating those. Those with a high baseline LDL, greater than 190. And then primary prevention, utilizing for those who don't have established disease and are between the ages of 40 to 75 to use a risk calculator that was updated from the Framingham calculator that they talked about 10 years ago. This all makes sense, and we don't have to figure out who is a CHD risk equivalent. We just know that these are patients that need to be treated. So their recommendation was to treat with statins and wait, don't use drugs that don't have evidence, or wait for those drugs that do have evidence, and use the potency for those who have established disease with the highest possible intensity therapy. So this is a major reversal. It used to be go low and go slow. Here they're starting to say go high and work your way down. Moderate intensity statin is where the bulk of the statins fall in terms of the higher dose established statins. Highest intensity currently of the statins is 40 to 80 of Atorva, generic, and Rezuva 20 to 40. And then the lower intensity statins are the lower dose statins that many of us grew up on in terms of that evidence. And the evidence suggests that higher works better. So what does this mean? For the elderly, if you have established disease and you're greater than 75, you should use a moderate intensity statin. Don't use the highest dose for the elderly. For those who have diabetes, again, use moderate intensity lipid lowering. Those with a risk calculation of greater than 7.5% use a moderate or a high intensity statin based on their age and on the degree of risk. So if it's greater than 7.5%, treat with a moderate to high intensity and then a moderate intensity statin if it's between 5 and 7.5%. This is where a great deal of controversy occurs. We have now, don't look at your baseline, don't look at the cholesterol, look at what diagnosis you have as being a risk equivalent for having a myocardial event. Then the other piece is you don't have to target to an LDL level. They state that there's no evidence to show that going lower is greater. And this is where the biggest controversy is, and I sum it up as this. You're in the middle of a voyage, you don't know what your baseline was, because you may not have started, you just started them on a medication. And you don't know where you're going to, and you're in the middle of the voyage, so how can you navigate? So the controversy about the risk calculator and the fact that they've eliminated targets has created some of the disturbance in terms of the controversy. I tell you, it was one of the hottest debates I've ever seen in the American Heart Association last fall. So the risk calculator looks at these factors, which really kind of pulls in. If you're non-diabetic, but you have these other risk factors, these are the what you can plug in, and it's downloadable to be able to look at. You can download it for your laptop or for your iPhone or your Droid. The paper that justifies the use of this new risk calculator, which is pooled analysis of about 5 or 6 different databases, was validated and presented in JAMA this year. Really focuses on 3 things. That the observed and predicted correlations were high for 5-year risk. They were also high in indicating that these risk equations were well calibrated to the population that they're designed to look at, and they demonstrate moderate to good discrimination, which are all biostatistical tools. Finally, what about combinations? Focus on lifestyle, focus on adherence, but then if you're not at your expected level of LDL, consider combinations. And that's where that comes into play. The risk decision for older adults merits discussion to consider the adherence to optimal lifestyle, potential for benefit, looking at drug-drug interactions and side effects, everything that we've talked about. Why not continue? Current RCT data does not focus on LDL lowering, it focuses on preventing events with statins. That's why they said we can't make a recommendation there. But that's what's caused the confusion at the bedside. Therefore, the net benefit from a treat to target approach they felt wasn't helpful. And one last comment, the NLA came back and said targets are important, but then they made non-HDL the primary target along with LDL, and they focused on a number of risk factors, and they do have targets. So is it targets or is it not? It's, I think, going to be still up to you, but the biggest piece is 10 points here. Consider balancing benefit and risk. Really, LDL is the primary target of therapy. Everyone agrees to that. The primary therapeutic target is LDL, and that statins are proven to reduce risk. And then when risk is high, treat intensively as possible. A moderate intensity statin is okay, and combinations are okay when you need to get the patient to where you feel that they need to be. So last thought, older patients should be considered as first-class citizens and consider treating their cholesterol. That's it. Thank you very much.